Bismillah ar-Rahman ar-Rahim. Alhamdulillahi Rabbil Alameen. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Now, my dear friends and colleagues, now this is today the presentation actually, which was given by Dr. Javed Sami under supervision of me, and its topic is common respiratory diseases in shadow of cause-effective investigations. A very brief discussion for the GPs of Pakistan. Now, this presentation is for the general practitioner of Pakistan. I am Professor Sayyid Ali Haider. I am talking on behalf of Dr. Javed Sami, and I am a visiting professor of medicine at the Janatian Medical University. Now, try to understand this first of all, the basic anatomy and physiology of the respiratory system. Upper respiratory tract is the lower respiratory tract. The respiratory apparatus, nose, larynx, then trachea, then bronchial tree, and alveolar spaces into interalveolar spaces, that is called, and septals, alveolar membranes, and interstitial spaces. This last parts are of the what is called the pulmonary parenchyma. We call it pulmonary parenchyma histologically speaking. Now, this is the tracts which are shown here. Look how much nature is provided for the lungs as a gross appearance and the anatomical appearance is concerned. So, trachea and divided into the carina, into the right principal bronchus, left principal bronchus, then the upper lobar bronchus, middle lobar, lower lobar bronchus, globular bronchus, segmental bronchus, dividing again and again, and the bronchioles are formed, which are again subdividing. At one time, only the last part is called the terminal bronchiole. And this is the terminal bronchiole. Now, it consists of this terminal bronchiole has a neurovascular bundle attached with it. There is pulmonary vein and pulmonary artery. And these actually this terminal bronchiole is a feeding bronchiole, where the gases at the alveolar spaces here, they are exchanging. This is the prime function of the lung. That is, the oxygen will be taken inside and the oxygen will come out. This is the primary or the prime function of the lung, other than other functions as well. Now, this is the prime function. So, anything which is affected from here to here will cause difficulty in the exchange of the gases. This is the gas exchange process which is going on at the terminal bronchiole. The alveolus is seen here. This is one alveolus which is drawn. Air moves in out from the alveolus. The oxygen is going, carbon dioxide is coming out. Then oxygenation occurs in the pulmonary veins, and on the left side of the heart it will come. And the carbon dioxide is the deoxygenated blood coming from the right part of the heart. And now it ends as the expulsion of the carbon dioxide. If there is less amount of oxygenation, it is called hypoxia, and the carbon dioxide is moving out, but due to some reason it is not coming out easily, then there will be retention of the carbon dioxide in the blood, which is called hypercapnia. So there will be hypoxia, which is terminology we use, and hypercapnia, the terminology which are used if there is dysfunction of this system, respiratory apparatus. On the basis of these anatomical or physiological aspects, the targeted topics for the general, we discuss for the general practitioners as a concern, and the bronchial asthma, target the organs will be bronchi and the bronchioles, and the COPD, the target organs will be bronchi, intervalvular septi, and alveolar spaces, pneumonia, pulmonary parenchyma. Pulmonary hypertension, pulmonary arteries and veins will be involved. There will be pulmonary arterial hypertension and pulmonary venous hypertension. ILD means interstitial lung diseases. It will target the interstitial spaces, which is in between the terminal bronchioles. You see these spaces where the fluid is coming inside and out. It is the interstitium of any tissue. It is the interstitium of the lung. After some of these topics will be discussed, then we go for the interpretation of the pulmonary function tests. Bronchial asthma is a big topic. It is actually the hypersensitivity or the sensitivity or the hypersensitivity of the bronchi and bronchioles and where the smooth muscles are there. It will cause spasm of the bronchial musculature, and it will cause wheezing. So it is the remitting, relapsing type of the condition in most of the cases where there is a sensitivity or hypersensitivity of these areas where there will be bronchial spasm. And this is actually the clinical definition. Now, it causes the air path of the lungs to swell and narrow. This is the pathogenesis which they are describing. What happens is that it becomes narrow and swelling occurs. Actually, there is inflammation which is going on because of the hypersensitive reaction. Due to this swelling, the air path produces excess mucus. And secondary effect is the mucus production, making it hard to breathe now. So caliber of the bronchi will become reduced, and if you try to expire, it will cause wheezing, will result in the coughing and short breaths or wheezing. The disease is chronic and will interfere with the daily work, of course. Investigations are concerning usually clinically diagnosed, and X-ray test usually normal, nothing abnormal. Blood CBC may show eosinophilia in most cases, not all. IgE levels are usually higher. Depending upon the eosinophil count and the IgE levels, one is called extrinsic asthma, one is called intrinsic asthma, and third type of asthma is mixed asthma. So extrinsic asthma means that the outside allergens, they are coming inside, antigens that are, and it causes the hypersensitive reaction. And it is associated with the atopic condition this is. The type 1 asthma is atopic asthma. Type 2 is called intrinsic asthma. For example, some of the feelings and some of the reflexes which are in your body, they will produce it. For example, excessive laughing, excessive weeping can cause bronchospasm. Now here the pathogenesis is intrinsic, not extrinsic. So these reflexes will produce hypersensitivity again the same way. But the IgA levels usually are not higher in these conditions. Mixed type, both components are present. Sputum DR can show eosinophilia and its derivatives, as for example the Charcot-Leyden crystals or Hirschsprung spirals may be seen, may be the clue. It can also be diagnosed by the provocation tests, for example histamine-induced bronchospasm and the other cholinergic drugs which are available, which can, if you inject, it will it will cause bronchospasm in the sensitive patients. Then you have to confirm it by the intradermal antigen test. Extrinsic type of asthma can detect a specific allergen, and you can make serum. Anti-serum can be prepared and can be injected intermittently for 2 to 3 months. It can benefit in some conditions in some of the group of the patients. The management, the preventive measures, yes, of course, avoid smoke, dust, and environmental pollution. Wear surgical masks, put surgical masks, get rid of the internal plants, pets, for example, cats, carpets, woolen clothes, blankets. These are the sources of the allergens or antigens. Avoid smoking, passive smoking, both can cause it. And daily exercise should be done as a slow walk, because exercise-induced asthma is also seen. Then it is again the intrinsic type of asthma. Avoid cold drinks and fast foods. Use montelukast, that is nicotine inhibitors, or ketotifen, which is the slow reacting substance inhibitor, or you can give also the preventive long-acting antihistamine, like for example loratadine, as a pharmacological secondary prevention. In my opinion, the 3 drugs should be used if there is severity of the condition. Breathing exercises, chest physiotherapy is needed in these cases. Treatment acute attack, if it's there, oxygen nebulizer with the short-acting beta-2 agonist, that is salbutamol or tributylin. If it will not work, ascend it to the anticholinergic ipratropium bromide. Will be also be can benefit the patient. Then you can either give the salbutamol or tributylin subcutaneously, and in certain conditions, if there is a very severe attack, you can give the adrenaline controlled subcutaneously. Doctor should be there, physician should be there to monitor it. Or you can inject the dexamethasone, or you can inject the xanthines, for example, intravenous theophylline or aminophylline, drop by drop. In the remittent period, you can use the short-acting beta antagonist, long-acting beta agonist, short-acting or long-acting the anticholinergics, that is muscarinic drugs, antimuscarinic drugs. You can give the long-acting xanthines like theophylline derivatives in SR forms, steroids as the last resort. All can be chosen dependent upon the severity of asthma. In the content, if there is a content infection, in my opinion, there is always inflammation will be there, always, in most of the cases, because there is stasis and the proximal bacterial overgrowth will produce it. So, short-term broad-spectrum antibiotic should be given in these cases. It will definitely benefit the patient, according to the American College of Physicians. Now, chronic obstructive pulmonary disease, what is this? As the name suggests, it is a chronic, progressive, obstructive nature of the disease, and usually result from the excessive smoking, cigarette or cigars, hookahs, vaping, e-cigarettes, environmental pollution, infections, chronic persistent asthma of long duration. Generally, it may be genetic. For example, in cases of the Kata-Jana syndrome or the ciliary motility disorders or alpha-1 antitrypsin deficiency. In cases of cystic fibrosis, which is genetic in origin again. There are two polar ends of the disease, actually, emphysema and chronic bronchitis. There are two links. There are third link you can put is the chronic asthma. There are fourth link you can put as bronchitis. The fifth you can put another disease which is called the bronchiolitis obliterans. You see in the old ages. Actually, the acute bronchiolitis is seen in children, but this is bronchiolitis obliterans, and this is called histiocytosis X actually. It is also called obstructive nature of the disease, or the disease is actually interstitial lung disease, but it comes under the heading of the obstructive nature of the disease. There are 5 links like Olympic rings, but there are 2 polar ends. One is emphysema, one is chronic bronchitis. In between there will be chronic asthma or bronchitis or bronchiolitis obliterans. Pure form of the emphysema is rarely seen. Pure form of chronic bronchitis is rarely seen. Dominant emphysema or dominant type of chronic bronchitis. Yes, this is the correct terminology actually. Clinical manifestation in comparison, because the 2 polar ends are there, the minimal coughing with no to small amounts of sputum in case of emphysema. So coughing is not a problem in these cases. But in the other polar end, in chronic bronchitis, there will be expectoration, purulent, and very excessive coughing, especially in the morning. And in both, there is effort intolerance, of course, the shortness of breath. The important thing is this, that in emphysema, the major problem is dyspnea. And in chronic bronchitis, the major problem is expectoration. Mainly these are the 2 differences which I have said to you. Over distension of the alveoli which occurs actually in these cases, causes the diaphragm to flatten and AP diameter to increase in both conditions. There will be digital clubbing, and there will be heavy build, coarse capitation, central cyanosis in chronic bronchitis, because the BMR will increase in these patients. So they will eat much and much, and there will be obesity associated with it. But in cases of the other one, that is in emphysema, there will be barrel-shaped chest. They are pink stained color, they are called pink puffers, while in chronic bronchitis they are called blue blotters, because cyanotic tinge are there. In emphysema there will be loss of weight. In chronic bronchitis there is gain of weight. Hyperresonant percussion notes and sibilant bronchi are present in emphysema, while there will be the hyperresonant percussion notes with capitations, coarse capitations in the different parts of the lung. Now this is the difference between the emphysema clinical findings and the dominant bronchitis finding. Barrel-shaped chest, yes. You see in this diagram the accessory muscles are working, pursed lips, expression, central cyanosis may be there, reduced cricosternal distance here, because the clavicles go up, because the muscle is contracted, the sternocleidomastoid, trapezius, pectoralis major, intercostal indrawing during inspiration. And inspiration is the indrawing of the subcostal also. Inward movement of the lower ribs and inspiration. There will be low flat diaphragm, because the heart sound which should be heard here, they will be rather more clear in the epigastrum, because there is the distended lungs covering all over the chest. Auscultation accordingly. If it is bronchitis, you will find basically the sibilant sonorous bronchi or capitations. In emphysema, the sibilant bronchi, wheezing. apex beat is not available usually, and there will be hyper-resonant notes in both conditions. Diagnostic studies in this condition are X-rays early in the disease may not show abnormalities. You need good eyes to see the X-ray. What I will say, how to interpret the X-ray. If your keen eyes can detect, you can detect it. History and a physical examination is needed, of course. Clinical examination is of utmost importance. Pulmonary function studies can be helpful. In this case, there will be reduced FEV1 and FVC, and there will be increased residual volume and total lung capacity in comparison with the other condition which is called the restrictive lung diseases. ABGs will be good, PO2 will be reduced, but the retention of the carbon dioxide hypercapnia will be there, especially in chronic bronchitis. pH is definitely because of the carbonic acid is forming more and more as a retention of the carbon dioxide. There will be respiratory acidosis, which will compensated by the bicarbonate level. It should be compensated by the bicarbonate level. This is the X-ray characteristic of emphysema. Look, the tracheal center, the hypertonsillency will be there. There is straightening of the heart, borders very straight, flat dome of the diaphragm, clavicles is up. The required and external space is reduced, and all the costophrenic, cardiophrenic angles are normal. But in spite, the chronic bronchitis X-rays are dirty X-ray because of the bronchovascular markings are exaggerated. There are many in numbers. They are touching the lateral wall from upside down, It is a dirty X-ray. It may be associated with the cardiomyopathy rather than a straightening of the heart. Hypertonsillency may be there along with it, and the flattening of the dome of the diaphragm will be there. But important thing is this: there are a lot of bronchovascular markings will be found in the chronic bronchitis. They are called bronchitic changes according to the radiologists. Now, collaborative care is there. Of course, there is no treatment. Avoid smoking, number 1. 2, the gold standard is oxygen therapy, intermittent at the house, home therapy. It will raise the PO2 in the expired air, treats hypoxemia, and titrate to the lowest effective dose. Intermittent, 2.5 liters per minute for 10-15 minutes. And rest will be given for 45 minutes and then give again 15 minutes. And this the period will be increased and inspiration of oxygen will be decreased. Now this is how the patient actually will feel much relief rather than you go for the fancy therapy. The third option is the pharmacological intervention. The bronchodilators can be used like the short-acting beta agonist, salbutamol, or the long-acting beta agonist like salmeterol, anticholinergics like ibuprofen bromide, and the immunophilins may be helpful. They are not the treatment of choice actually. Steroids as a last resort you can give if they are not working and there is much bronchospasm and the patient is in curve, then you can give. The antibiotics if contact infection is there. Antibiotics have got a role, of course, in this condition because there is stasis and there is the bacterial overgrowth proximal to the obstruction. Now coming to the pneumonia. Pneumonia is the acute inflammation of the lung where the pulmonary pyromycardia is involved. There will be consolidation, that is called. Inflammatory condition of the lung affecting primarily the microscopic air sacs alveoli. The alveolar ducts, all are involved. And this is, you see in these cases, which we call as the pneumonia. If there is a limited space of the lung, it is called lobar pneumonia. If there are both lungs are involved, then it is called bronchopneumonia. Etiologically, the commonest pneumonia in our country is the community acquired. Yes. It is caused by the Streptococcus pneumoniae, but it may be caused by the other bacteria, Mycoplasma pneumoniae. It can be caused by the others as well, Klebsiella pneumoniae, etc. But the commonest one in 90% of cases, it is Streptococcus pneumoniae. Now add recently the coronavirus in the MSI. Now this is an important point to be ruled out before you are going to diagnose. Everybody afraid of it, because the coronavirus primary pneumonias are very characteristic type of the pneumonia. This is not the topic of discussion actually, because I will take much time describing the coronavirus invasion in the lungs. The presenting complaints, the fever without chills, they will be cough. It will be productive in case of the chronic bronchitis. It will be dry in the case of the emphysema. Chest pain, breathlessness is more seen in the emphysema than in chronic bronchitis. Hemoptysis is a part of it because of the rupture of the bronchiolar arteries. Invasion of the infection inside it can cause hemoptysis, or it is because of the constant rubbing of the surfaces which cause lacerations and cause hemoptysis. As a part of the multi-organ dysfunction syndrome, because infection travels inside and it will cause the bacteremia, septicemia, pyonemia, SIRS, that is systemic inflammatory response syndrome, and MODS, the multi-organ dysfunction syndrome. In many of the cases, if there are more, they have got high risk factors, they will cause this type of a presentation. It may be an incidental finding. For example, in HIV, there is pneumocystis carni can cause it, but without symptoms. Patient is hardly any giving symptoms, very short spasm of cough or low-grade fever is possible with this. Again, in HIV, remember the atypical mycobacterium can cause the pneumonias. Again, the picture will be very near to the tuberculosis. Now, this is pneumonia as all. The central, either the headache and loss of appetite, mood swings because of the bacteremia or septicemia. Now, systemically, high-grade fever, chills, skin cleanliness, blueness will be there. There will be tachycardia, there will be low blood pressure, there will be nausea and vomiting, there will be arthralgia, muscular pain is much, fatigue, aches. It is a viral type of infection, or viral pneumonia will cause much fatigue, much aches. The lungs cough with the sputum of falcum, shortness of the breath, and pruritic chest pain if the pruritus is there. And there will be hemoptysis because of the invasion of the bronchial artery. The risk factors are age, these are the risk factors, occupation, addiction, comorbidities, for example, diabetes mellitus, comorbidities like immunosuppressions, thickly populated areas, more chances. Winter seasons, they are easy for the entry of the Streptococcus pneumoniae specifically. So give the vaccination against it before it comes, specifically in the old ages. And the immunosuppression, of course, is again the important risk factor. We score the patient in this session. It is called port scoring system, or Genoa scoring on other scoring system as well. And see that the patient, how much score he has achieved. Accordingly, there will be a mortality of this patient. The two ends of the lives are at risk, actually, in most of the cases. Very, very small age groups and very high age groups. Both ends are in danger. Now, clinical examination inspection affected part showed restricted movements. The patient take care will be central. This is very important. It should not be displaced in pneumonia. There will be tenderness and slow movements of the affected area. And there are tactile vocal formalities which will be increased in this case because of the direct sound is transmitting through the wall. Percussion notes are dull percussion notes, of course, because of the consolidation. Now, auscultation, bronchial breath sounds. What is bronchial breath sound? Inspiration is equal to expiration. Inspiration as high pitch as there is expiration. And there is a gap between the inspiration and expiration. This is called bronchial breath sounds. Very characteristic finding. With coarse capitations in this condition. And there will be VR which is increased, it is called bronchophony. For us, it is, if the VR is increased, it is called bronchophony. If all is present, it is definitely consolidation. And the clinical examination. Investigation CBC will cause, show you leukocytosis, random blood sugar, chest X-ray will very characteristic, urea creatinine electrolytes for the scoring system, because there is septicemia. You have to calculate the score by doing urea creatinine electrolytes. Urine DR should be done. It should be done and for culture and sensitivity also. It should be done for the AFB to exclude. It will also be done for the gene expert and sputum. Urine will be done for the DR and pneumococcal antigen. Easy to detect it. CT test in selected cases where there are confusion or there are comorbidities. This is very characteristic lobar pneumonia. You see how this ends. The whole part is homogeneous opacity, there are hardly any few aerograms are seen only. Now, this is very characteristic of the lobar pneumonia. In bronchopneumonia, both lung fields are involved, both sides are involved, and the pitchy opacities are seen in the bronchopneumonia. The lines of management is the general measure rest, specific measure you give oral parenteral antibiotics for 10 days, symptomatic measures, antipyretics, analgesics, cough suppressant can be used. Dietary measures, high protein diet should be given, not carbohydrate. Carbohydrate should be cut off because it will produce more carbon dioxide and there are chances of hypercapnia or carbon dioxide retention. You can give a high protein diet or the moderate fat diet. The preventive measures are yearly vaccination. This should be done in old population, specifically speaking, very young children also should receive these vaccinations. Now, ILD is a diverse type of illness, very diverse. It cannot be classified confidently by anybody in the world. It involves the interstitial spaces of the lungs. The classification actually WHO has given is very, very complicated. They all cause in the end, the fibrosis of the lung. This is very important. Is the fibrotic nature of the disease. It limits the interstitium. It will pull the alveolar spaces. It will aggregate the alveolar spaces. The most lengthy and difficult topic of pulmonology. This is a very important point, that it is a very difficult topic. All cause, what you have to remember is the involvement of the interstitial spaces, fibrosis of the lungs, and it is a restrictive lung disease. That's all. Otherwise, refer to the patient, of course, to the pulmonologist who is expert in ILDs. All end up in the secondary because of the pressurization effect, the pulmonary hypertension leading to the right ventricular failure, leading to the congestive cardiac failure. This is the fate of this type of the disease. This is how it presents. Now here is a picture. The spaces. Look, these spaces. Look, they are involved. This is the interstitial space where the blood vessels are crossing. If fibrosis occurs, then it will definitely it will cause the obstruction to the vessels in the interstitial space. So this is the concept of the disease. The management is you use bronchodilator, oxygenation, and nebulization, and giving the steroids, immunosuppressive drugs, because most of the fibrotic nature of the diseases of the lung or ILD, they are autoimmune in nature. Rheumatoid arthritis will end up in the ILD, the Sjogren syndrome, and systemic sclerosis, and the other vasculitic syndromes. They are all autoimmune in nature. RA is usually positive in this condition. Fibrosing alveolitis is the commonest disease of this ILD. So we give the immunosuppressive if they are failed. Methotrexate and azathioprine and other drugs can easily be handled. Chest physiotherapy exercises. And end-stage pulmonary disease, you have to go for the lung transplantation before there is increase of the pulmonary pressure. Arterial pressure should be less than 35 if you go for the lung transplantation. Before the pulmonary hypertension develops, plan for it. The pulmonary hypertension increased pressure in the pulmonary arteries of the veins. Primary pulmonary hypertension, idiopathic. It is genetically determined. Only the young females are often involved in this condition. Males are rarely involved. Young females. Main presently complaint is upper intolerance. Treatment is to reduce the pulmonary pressure. So we use the drugs like deltazyme and nitrates, sildenafil is using nowadays, bosentan, endothelial receptor blockers drugs, and warfarin sodium, because pulmonary embolism will be the cause, may be the associated cause, or maybe will be the initiating cause for the development of the pulmonary hypertension. If all therapy are failed, you go for the orthotropic lung transplantation. Now, secondary pulmonary hypertension is commonly associated with the COPD, interstitial lung disease, mitral valve diseases, chronic recurrent pulmonary embolism. It results from this, either arterial hypertension or the venous hypertension. The treatment is to remove the initiating cause if possible. You give the intermittent oxygen therapy, nebulize it, bronchodilator should be used, calcium channel blockers should be used, nitrate, diuretics, warfarin, sodium to protect from the microemboli, bosentan, endothelial receptor blockers should be given. Try these drugs to reduce the afterload and to reduce the preload on the heart. You use these drugs. In the case of the end stage, the pulmonary disease, only the option is the cardio and lung transplantation. There will be cardiac transplantation along with the lung transplantation. That will be the answer. It can cause the quality of life for 5 to 10 years. Pulmonary function tests, although it is difficult, very easy to understand. It is not a very, very complicated topic. Actually, we are doing because to differentiate between the obstructive nature of the disease with the restrictive nature of the disease. What are the obstructive lung diseases? Name it. Bronchial asthma, chronic progressive emphysema, chronic bronchitis, bronchiectasis, bronchiolitis. These are the obstructive lung diseases. And examples of the restrictive lung diseases, like, for example, the ILD, pneumoconiosis, kyphoscoliosis, because of the musculature of the skeleton of the thorax is involved, and muscular dystrophies, and in cases of the myasthenia gravis, weakness of the muscles. So you cannot do the normal lung function is lost. So there will be retention of the carbon dioxide and there will be hypoxia in these conditions. The information to gain from the PFT is that how we'll do it. There is a apparatus specifically designed for it. Patient should be there. Half hour he has to take rest. There will be no smoking before this test. And it is the information which we give, it will give is this, that you can differentiate between the restrictive lung of disease and the obstructive lung of disease and the severity of the disease and the outcome of the disease. The type of the pulmonary function test is spirometry. Important parameters of this. There are a lot of parameters. What you have to remember is the vital capacity, forced vital capacity, deeply inspired and forceful expired. That is forced vital capacity. Forced expiratory volume in 1 second, calculated by the computer, FEV1. So if the ratio is FEV1 and FVC, it is important. If FEV1 is definitely increased, rather, the ratio will be increased. If forced vital capacity is reduced, the ratio will be reduced. Inversely proportional, directly proportional. Now, lung volumes are also be calculated, like residual volume, like the total lung capacity. The two parameters are enough. The definition actually, the predicted normal values of the geographical community will be calculated, first of all. And then say that if it is less than 70% or greater than 110% in our country, these are the normal values. Less than 80% is normal. Abnormal test should be defined as less than 70%, and it is more than 110%. The lowering of this and the emerging of the or higher values are both important. Predicted values, we go for the predicted normal values. Comparative study should be done. For example, here, in obstructive lung diseases, the forced vital capacity is reduced. Forced expiratory volume is reduced. If you cut it down as a ratio, it may be normal because it is inversely proportional, it is directly proportional. It may be reduced. If it is much reduced, forced vital capacity, then definitely it is reduced. And in this case, the residual volume and the total lung capacity is increased. This is the volumetric study. So you have to calculate the FVC, FEV1 ratio with the FVC and the residual volume with the total lung capacity to diagnose this condition. In restrictive lung diseases, the forced vital capacity is reduced. The forced expiratory volume in 1 second is reduced. The FEV1 by FVC is normal, but it may be increased to 110% predicted values rather than decreased because the forced vital capacity is much reduced. If it is much reduced, it means that the ratio will be increased. The residual volume and THC is reduced, not increased. In this way, you can compare the two diseases, the obstructive lung disease and the restrictive lung disease. Now this is only the introduction which I have given about the pulmonary function test, but you can interpret it in front of you. The predicted value, for example, is 70%. The lower value is, if the patient is 60%. In the same fashion, the other parameters can be calculated. How much it is reduced and how much it is increased. 70% reduction, less than this, reduced. More than 110% increased. So in this fashion you can calculate and you can go for the differentiation. I hope that you have understood this very brief discussion of the respiratory tract diseases according to the phenotypical markers I have said. So, inshallah, we will meet again. وَمَا عَلَيْنَا إِلَّا الْبَلَاغُ. Assalamu alaikum wa rahmatullahi wa barakatuh.